afternoon, everybody, and thanks very much, Sam. I'm here today to introduce you to Dr. Saif Ahmed. He's the Deputy Chief Clinical Officer and Associate Medical Director for Community and Neighbourhoods for Tameside and Glossop Integrated Care NHS Trust. It's a big title. As well as that, he is the Clinical Director, Digital Transformation Lead at Health Innovation Manchester. We're going to have a bit of a chat this afternoon about virtual wards. Saif will talk a bit more about what they are in a second, but just so you know, they're a relatively new concept. I consider them to be trailblazing, hence talking about them here today. Virtual wards leverage tech to provide hospital-type care outside of a traditional hospital setting, and they allow providers to monitor and care for patients remotely using tools including video conferencing, wearable devices, and patient portals. Saf's going to do a presentation now to explain a little bit more, and then after that we're going to have a bit of a chat. If you've got any questions, please do what you've been told to do this morning, and apparently they'll pop up on this iPad. So thank you very much.
Afternoon, everyone. I'm Dr. Saif Ahmed. I've already been introduced, so thank you for that, Charlotte. Just in terms of what I'm talking about today is virtual wards. So I'm hoping some of you know about this already. And this is also for you here to be a potential resident and a GM patient as well, potentially of a virtual ward in the future, or any of your family. So I think it's really important that people start to understand what virtual wards are. Just to give you a bit of a definition here. So a virtual ward is an alternative to NHS bedded care. And the idea of this definition has been quite hard to actually come by because there's been lots of debate around this. But the idea is that if you need an acute bed in an NHS hospital, this is an alternative in your own home. So you are ill enough to be in a hospital bed. It's not about general practice looking after you in your own home. This is about those people that would actually need a hospital bed. And that's because of the crisis we are facing, unfortunately, in the NHS, that we need this kind of transformational care to kind of kick in. So just in terms of virtual wards enabled by technology, so we're very much looking for patients to have their data through an app or a website that they use in their own home. That then transfers onto a dashboard that's clinically monitored by a clinical team. And it also sets parameters whereby if there's any issues with that patient, it's highlighted to the clinical team and they can act on that straight away. Just in terms of why we're trying to solve this, so I've been a doctor in the NHS for over 20 years, and I don't like being pessimistic, but we are at the worst ebb of the NHS that I've ever seen. It's hit crisis point, and because of that, our hospital pressures are exceptionally bad. I was in A&E on Wednesday morning during the junior doctor strike, and we had an 11.5-hour wait to be seen at that point. And that was a lot worse over the Christmas time, and as we move towards winter, we really need to enable this kind of technology and virtual wards so that we don't have the crisis that we had last winter. Huge workforce pressures after COVID. We've had a number of staff leave. Certain jobs have become a lot more difficult. Those people working in ITU, those people working in A&E, suffering from PTSD, all sorts of things where colleagues died, and that's really starting to show now. And then staff morale and resilience. As you know, we had the junior doctor strike last week. We've had nursing strikes. It's been a really torrid time in the NHS. So we're really hoping that this is something transformational that starts to change that rhetoric. And hospital isn't really a safe place for people anymore either. So I see patients who unfortunately have very long length of stays in hospital. They pick up hospital-acquired infections. That gives even longer lengths of stay. And then there's this never-ending circle of morbidity, mortality that's just not right, and we need to change that. So the national ask was to set up virtual ward beds, 40 to 50 per 100,000, meaning for Greater Manchester we need to have, by March 24, 1,100 virtual ward beds in the community serviced by our 10 trusts. And we've currently got 9.8 million of funding for 22-23. As of March, this number's gone up now, but we've got 467 virtual ward beds functioning, and over 400 patients each week in those virtual ward beds across Greater Manchester. So we're heading in the right direction. We've had nearly 1,960 bed days saved just from the virtual ward beds that we've put into practice so far. And the idea is to obviously scale this across Greater Manchester. Urgent care funding, the UEC funding, is up to 20 million for next year overall for virtual wards, and this is going to exponentially really increase, because this is one of the reasons we want to try and get a new model of care based in the NHS for all patients in the UK. Just moving on, just a few patient insights here. So I think it's really important to understand why we're doing this. And the strapline, I'm glad to be home even when you come back from holiday. It's really key around how we've seen virtual ward patients feel about being in their own home, being looked after. I am the clinical lead at Tameside for our virtual ward, and I was seeing a patient last Wednesday, and she was 92 years old, using her own kit in her own home. And she was, while she was talking to me, she was making a cup of tea. She was up and about and walking around. If she'd been in a hospital bed, she would have been put in a hospital bed, and she wouldn't have probably moved for about 3 or 4 days. Those 3 or 4 days would have deconditioned her to the point where she wouldn't have been able to walk again for another 6 weeks or so. And that's that muscle mass that you lose in 10 days of a hospital bed is 10 years of muscle mass. And we're doing this all the time in the hospitals at the moment, where patients are deconditioned, and then they're very hard to get out of hospital, and they end up in intermediate care facilities, and it's just not right. So that insight of patients moving around their own home, being able to make cups of tea, but also having the care at home that they need. They felt reassured by hospital teams being in contact with them daily, so they have a daily ward round from a consultant or a GP, and they have comfort calls 4 times a day from the virtual ward staff. But there were pressures around carers feeling that they may be overburdened because they're already overburdened in their own homes, and how we support that. So there's some barriers there as well. And effective onboarding onto digital solutions is really key. So Wi-Fi connectivity, the ability for people to use those kind of tools as well. Clinical insight has been difficult because transformational change in the NHS is very difficult, and behavioural change for clinicians like myself is also very difficult. We're used to parameters, we're very risk averse, and moving towards new transformational models of care has meant that it's been quite difficult actually to get the clinical buy-in that we've wanted to accelerate this as much as we have. But we're starting to hear from patients how good this service is, and we've also made it exceptionally safe, which meant as we are now starting to get that clinical buy-in across Greater Manchester, and then acceptance that this is a model of care that we're going to be going with as we move on. Just to mention staff shortages, increased workload, calling burnout. What's really interesting in terms of our virtual wards, the staff absence and the sickness has been the lowest of any department in the hospital. People actually like working in virtual wards. They find it's more calm, less stressful, and we've got better retention of staff as well going forwards. Just in terms of barriers to adoption, as you probably know, just in terms of digital exclusion, so we've got nearly 23% of the population who are using digital services because of lack of money at the moment. The cost of living crisis has really hit home, and we have a number of patients that can't adopt these services. So we say, why are we building services that potentially a number of people can't adopt? And that's because what we need to do is free up the NHS so that those people that can't use these type of services do get the same standard of care. And they get face-to-face appointments, and they're able to be seen, because without freeing up those people that are digitally savvy and are able to use these services, we're then unable to see those people that aren't. And we are finding struggles in terms of language, in terms of ethnicity on our virtual wards, and that's still a barrier that we need to get through. And we're very much at the forefront of trying to tackle those things, because it's important that in Greater Manchester, where we have over 200 languages spoken, massive ethnic diversity, that we actually have a solution that's for everybody. Just in terms of how we've divided ourselves in Greater Manchester, we've got four integrated systems, which are the trust divided up into their affiliate kind of partnerships, and they service a number of different populations, and they're all using different tech at the moment. So they're using Current Health, Dignio, Docabo. Just to go into a bit of the tech at the moment, so the Current Health kit is a band that the patient wears in their own home, and it's continuous monitoring for 24 hours. And that sends observations to the hub in terms of blood pressure, respiratory rate, pulse, SATs, continuously monitored. And if any of those trigger, then the team become aware. In terms of the Dockerbone, the Dignio kits, they are actually used by the patient themselves, and they do their observations as you would have in a hospital, where you have your observations done 4 times a day. And they'll continue to monitor themselves, and if they trigger, then we call them and we get them involved. It's interesting at the moment in terms of the kit, because we don't know which one's the right one to use. This is very new. There's lots of providers out there at the moment building some of this kit, and the key for us is interoperability with our EPR systems in general practice and in the trust, so that we're not logging on to lots of different systems. Currently, we're not there yet, so this is a journey we need to go on in terms of how do we work with providers to actually start to build interoperability into our own systems and make it easier for clinicians, but also then easier for patients in their own home. Just in terms of, this is the GM Tableau dashboard, so we monitor all of the people in virtual wards across Greater Manchester through our Tableau dashboard. It's been really useful to see the kind of the increase in people in virtual warded beds, but it's been difficult. It has been difficult, and this is a completely new model of care. And technology as an enabler is really important for us in the NHS at the moment, because we don't have people. Our workforce is dwindling, and I massively see digital as an enabler. And it's how do we use digital to actually make the workforce work smarter. And just in terms of what we're doing now, so we're accelerating at pace across Greater Manchester. We're developing common pathways around frailty, around respiratory, around end-of-life care. We're also focusing on admission avoidance, so we're working with NWAS now, we're working with the 111 team and the Greater Manchester CAS to develop new pathways so that we can push more people into virtual wards. And we're there to harness the assets of the system as well, so working with out-of-hours teams, working with our community services and nursing teams that are out there, and general practice. And we're also looking to kind of optimize non-clinical activity at scale. And this is an interesting part in terms of how do we make sure we scale a solution for Greater Manchester so we don't have variation, we have really good outcomes for our patients. So that's me done. I'll move over to questions. Thank you.
Thanks, Saif. As just mentioned, if you do have any questions, please pop them on the app, and I'll put them to Saif. But I've got a few questions first, Saif, so if you don't mind. It would be helpful, I think, if you could expand on a typical patient who would be treated on or seen to on a virtual ward, what type of condition, and also what's the sort of average length of stay as well. You mentioned this is not sort of about replacement for primary care or community services, so just understanding a little bit more about the conditions and the sort of person who would be involved in that.
Yeah, so as I was saying before, we have kind of 2 main pathways that we've developed in Greater Manchester that we've standardized, which are respiratory and frailty pathways. In terms of respiratory, so people who have COPD, chronic obstructive pulmonary disease, we have a pathway for those patients. And typically the as-is state was patients with COPD who had an exacerbation would come into hospital, they would have all of their bloods and their chest x-rays done, they would then go onto a ward, have IV antibiotics maybe for 3 to 5 days, and either recover or not recover, become worse, need more antibiotics, and they would therefore need a hospital stay of maybe anything up to 10 days. Currently what we do, we see those patients in A&E, we identify them, and then we get the tech into their house, so we're monitoring their oxygen saturations, we're monitoring their blood pressure, and we get IV therapy teams to go to their own home. So the IV therapy and the IV antibiotics are given in the patient's own home rather than in a hospital bed. And we'll also send out teams who will take bloods every day, and those bloods are reviewed by the team back at the virtual ward. And that patient will typically stay on the virtual ward for anything up to 7 days. So our average length of stay for virtual ward patients is 7 days at the moment in Greater Manchester.
Yeah. What about, people might be wondering what happens if their condition does get more serious. Obviously, if you're in hospital, you might be moved to a more intensive ward. What would happen to a patient who's on a virtual ward if that scenario took place?
So what we do is when we put someone on a virtual ward, we build in triggers in the system in terms of their observations. So they have a News 2 score done, which is a score that allows us to assess how severely unwell someone is. And depending on if they trigger, what happens is our virtual ward hub will actually see that triggering on the system as an alert. They will call the patient, assess them, and then we can get doctors and nurses to go out to the house and assess the patient and decide what to do. If we can keep that patient at home, we will keep the patient at home. If we need to escalate them back into the trust, then we'll do so. So they bypass going through A&E or all of that process again. We would put them in the right place, essentially.
And presumably, if the information that the virtual ward is receiving is life-threatening, the reaction would be to send out
an ambulance.
Services.
Exactly, yeah.
Absolutely. I'd also be interested to know, you talked about that sort of digital divide and digital inclusion. Is a virtual ward an optional service?
Yeah, it's massively optional. So we have a full consent process. So we select patients, or consultants select patients when they see them, and then we will go and assess them as a team to say, do you want to be on a virtual ward? Do you have the support in place? Do you want to be? It's purely optional. It's not at all forced to any patient. But what we do find, what's interesting, is that patients pretty much always say, yes, I want to be at home. Because the experience through hospitals these days is not great. And having been waiting in a hospital waiting room for 12 hours before you're maybe in a corridor for another few hours, and then you're not even in a bed, it's quite distressing for a lot of people. Whereas being told, well, we can do all of this for you in your own home, loads of people want it. So it's a good way.
You mentioned, I'm just keeping an eye on the questions. I think we've answered the question about in a virtual ward, when the monitoring devices trigger, what is the response? Hopefully that's been covered. You've mentioned a little bit about the technology that's being used in Greater Manchester. You also mentioned some of the ongoing barriers. Do you think there's an opportunity for technology to address some of those barriers, particularly around things like language? You mentioned skin colour.
Yeah.
Is that something that you would be looking to
And
use?
these are all barriers that we're coming across now because we're just beginning to realise what's happening. So for darker skinned individuals, SATS probes measure slightly lower than they should do, which is an issue because we're acting on their 4 parameters that don't work. It's really important as well that this technology starts to become a bit more intuitive. It's able to monitor people's activity levels, all of those type of things, as well as just their observations. Because we know that someone moving around their house is more likely to be better than someone who stopped moving, so to speak.
Yeah.
But it's really important that the technology advances alongside, so wearables, things that are just not intrusive for patients would be really good. Because this kit is still quite intrusive for a lot of the patients. The bands that current health provide is quite good, but again, wearing a band 24 hours a day while you're at home is quite difficult sometimes, we've heard from patients. So hopefully the technology will advance in terms of it becoming simpler. As we go out now and put some of this tech in, it can take anything up to 2 to 3 hours to put the kit in for an individual in terms of training them with it, putting the kit in. If we could build things that were self-activated, that'd be incredibly useful.
Absolutely. Is there a desire to also link in with any technology that those people at home might already have, not excluding those that don't, but I'm thinking that particularly smartphones, if a patient has a smartphone, are you looking for ways to sort of utilise existing technology?
And there are the companies that we've listed above are starting to provide mobile apps that patients can download on their own devices and put the information into those mobile apps. So using wearable tech, things that people already have in their own home, would be really useful, especially if we're going to scale this across the NHS. Because each time we buy kit, so for example at Tameside and Glossop we have 90 Dockerbo kits, and that's limited because of the amount of resource we get in terms of how many we can buy. If we're able to use people's own devices to start to monitor, it changes the landscape quite quickly in terms of how many people we could have on a virtual ward.
Absolutely. Thank you very much, Saif. I've just checked. I don't think we have any more questions. No, we don't. So if you could thank Saif in the usual way. Thank you very much.
And thanks to Charlotte as well. Brilliant session. I wish we had more time on that one, actually.